I have no financial disclosures. By the end of this lecture, the attendee should be able to describe aspects of the nursing role in temperature regulation, discuss assessment and management priorities that actually optimize this temperature regulation, and to discuss how temperature regulation crosses all levels of care. Historically, there have been several non-pharmacologic temperature managements that have been available. Dr. Behringer has already spoken on some of these, including adding blankets or hot water bottles for warmth, cool sponges or sponge bath to reduce fever. Florence Nightingale, who is the founder of nursing, stressed keeping the air as pure within as what is without. She stressed the importance of room temperature, as well as opening windows and have direct light to improve the health of those that were ill. Hippocrates advocated packing severely wounded in ice in order to reduce the hemorrhage. Total body cooling for tetanus treatment was started in the 4th, 5th century BC. Mild hypothermia was successful implementation in the 1990s in patients with severe brain injury. In 1892, Sir William Osler experimented with hypothermia in persons with typhoid fever, showing a decline in mortality, as you can see, from 24.2% to 7.1%. Dr. Temple Fay introduced therapeutic hypothermia to modern-day medicine by cooling via cooling blankets, which is the ineffective treatment that Dr. Behringer was just speaking of. But in relation to pain from metastatic breast cancer, at 32 degrees Celsius for 24 hours. Hypothermia, there's some misspellings on this, I must apologize. Hypothermia after cardiac arrest, a study done in 2002 demonstrated better neurologic outcomes and a lower 6-month mortality rate. In 2015, the American Heart Association included guidelines for post-cardiac arrest care related to hypothermia, not hyperthermia. Body temperature facts. It is known that it is lowest in the morning at 37.2 degrees at 6 in the morning. It is highest in early evening to 37.9 degrees at about 2 in the afternoon. Children's normal temperature is higher than that of adults. The greater temperature variation among women menstruating is that it will be higher 2 weeks prior to ovulation and during. Elderly patients typically have lower body temperature than adults and children. Variation also includes, as we know, with strenuous exercise that increases heat production 20 times over the normal value and can be as high as 40 degrees Celsius. Core temperature measurements, as we know, that are available include oral, it's convenient, it's accurate, is it really reliable? Readings are lower than the actual core temperature, which, as Dr. Behringer has already discussed. Multiple variables affect accuracy and reliability, and this is usually lower than oral temperatures. The rectal thermometer temperature, however, is a common method that accurately and consistently reflects core temperature when endovascular is not available. Tympanic takes the heat from the membrane and the ear canal, and it is typically generally lower. In less than 3 months of age, however, it is unbelievably not accurate due to technique as well as cerumen. I'm sorry. Right. Thank you. Core temperature measures also can be obtained by axillary, which is lower than both oral and rectal. Skin temperature over the carotid artery. As the carotid artery is highly perfused, it is accurate, but it is still lower than rectal measurement. And temperature strips that are placed either on the forehead. We also have bladder temperature sensor. It is more accurate than rectal or the axillary method. Esophageal temperature probe. That accuracy depends on the actual proper placement of this probe. And the invasive cardiovascular sensor endovascular that he had discussed. So we have the invasive cardiac catheter for accuracy, the esophageal bladder methods behind, followed by rectal, oral, and tympanic in accuracy. As we mentioned, it is now no longer considered hypothermic management. It is now targeted temperature management. American Heart Association initially added in 2010 with revisions in 2015 that recommended all comatose adult patients with return of spontaneous circulation after cardiac arrest have temperature-targeted management initiated. To maintain the temperature between 32 and 36 degrees. The goal was to preserve neurologic function. There are some relative contraindications to temperature-regulated monitoring. Active uncontrolled bleeding, if they are able to follow verbal commands. Any recent surgery, known or suspected septic shock, arrhythmias, or a prolonged QT interval, more than 6 hours after return of spontaneous circulation. These are all contraindications to therapeutic management. In this particular slide, you will see what the induction is, which he has mentioned already, between 32 to 36 degrees, maintaining that targeted temperature following the 8 to 24 to 48 hours. With maintenance, with reheating, you want to limit that to 0.25 degrees Celsius an hour until you're to normothermia at 36 degrees. We'll kind of discuss some of these individually. Some methods to conventional cooling for therapeutic management include the cold saline, ice packs, crushed ice, that studies have shown is all over the place when it comes to actual regulation. The surface cooling method, with the picture that he had with the patient with a blanket kind of cooled over him, is also not as effective. The blankets and surface pads are also available in order to initiate the therapeutic cooling. The endovascular, or that circulating cool or warm fluids via that closed loop circulation, is what is ideal. There is also catheters with the femoral, jugular, and subclavian that are actually available on the market as well. During the induction phase, there is no specific mean arterial pressure or systolic targeted blood pressure. There's published protocols of a mean arterial pressure at greater than 65 millimeters mercury and systolic up to 80 millimeters of mercury. The systolic blood pressures less than 80 millimeters, it was recommended norepinephrine. Symptomatic bradycardia is also seen during the induction phase. There has been recommendation of dopamine, and the patients, you have to realize, can be able to tolerate a heart rate as low as 30 to 40 beats a minute. Overstimulation of the heart rate can actually decrease myocardial contractility. The goal in the induction phase is to minimize metabolic demand. Precautions for shivering as well as paralytics should also be considered. We should also be monitoring for seizures. optimize sedation with analgesia. During the maintenance phase in 2015, the American Heart Association had some recommendations. Post-cardiac arrest with the maintenance phase, they recommended for at least 24 hours after achieving targeted temperatures. It is reasonable to actively prevent fever in the comatose patient after therapeutic temperature monitoring. To prevent or have complications related to shivering, you must consider a BSAS scale, a bedside shivering assessment scale. This is something you may want to introduce to your nursing staff. This is started in the induction phase. It is a voluntary response to heat production. It results in increased demand. So if we decrease sweating, we are in the thermoneutral zone, We then have vasoconstriction. As we cool, we want to avoid the shivering because that will increase heat production. Explaining this to nursing staff may be a benefit to y'all to be able to have them understand why we are initiating this protocol. In the rewarming phase, the American Heart Association recommended after 24 hours. As I mentioned earlier, you want to rewarm them to 36.5 degrees Celsius at a rate of 0.25 degrees Celsius per hour. You would like to actively maintain this temperature at 36.5 for the next 24 hours. Passively maintain normal 30 for 48 hours after that. Some nursing considerations. There needs to be proper training for the various equipment, including the endovascular method for cooling. There are limits of treatment. Protocols should be initiated by the nurses and maintained. Proper parameters should be set within that guideline for when you initiate a protocol for the nursing staff to follow. There needs to be ethical guidelines. When is too much enough? When is not enough? We need to do more. There needs to be ethical guidelines. Knowledge regarding the pharmacokinetics should also be explained to the nursing staff. In the temperature regulated model, the initiation protocols are being used currently in multiple hospitals. Implications of these protocols can result in very positive outcomes, as Dr. Behringer has already mentioned. Emergency medicine and critical care nurses are integral in initiating and adhering to these protocols with temperature regulation. Nurses have a key position to develop strategies to improve compliance across all departments, including radiology, physical therapy, respiratory therapy, and the such. In conclusion, assist nurses by having these protocols. Define a set temperature and what that intervention should be. Develop an interdisciplinary manner in order to foster best practice for your patients. Encourage nurses to see protocols as a guideline, not necessarily a recipe. And explain the rationale behind thermoregulation strategies. That's all. Thank you.